Good evening, everyone, and thank you for joining us for tonight's Woo You special event. Today, we are joined by Dr. Andrew Morgenstern, and he's going to discuss pupil size matters, the pharmacologic treatment of presbyopia that actually works. I'll be your host tonight. My name is Dr. Ariel Sorenzi. And a big thank you to Lens Therapeutics for supporting tonight's event. This will be worth 1 hour of CE credit, so please be sure to attend for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link that is in the chat now. It'll also be there when the webinar ends. CE certificates will be delivered via email within about 4 weeks and sent to ARBO with your OE tracker numbers. But we'll also have a QR code at the end of the presentation where you can scan your OE tracker app and get your credit instantly. And then we will save questions towards the end of the presentation. You can find the access to the question area either in the chat box or the Q&A at the bottom if you're on your desktop. And then if you're on your phone, you can find the Q&A at the top or the chat feature under those 3 dots under More. So it's my pleasure to introduce our amazing speaker tonight. Dr. Andrew Morgenstern currently practices at the Walter Reed National Military Medical Center in Bethesda. I still messed it up, huh? Bethesda. He holds the prestigious role as the director of the American Optometric Clinical Resources Group, where he's charged with developing AOA's evidence-based clinical practice guidelines. He holds the faculty rank as the assistant professor in the Department of Surgery at the Department of Defense Uniformed Services University School of Medicine. And you've very likely seen him lecture before or read some of his content out in many publications, such as Optometry Times, to name one of many. Dr. Morgenstern has published numerous medical journals, book chapters, and research posters. Additionally, he is the co-founder and president of the International Keratoconus Academy of Eye Care Professionals. So we are so excited to have him tonight, and it's truly an honor to have you join. Here are his financial disclosures, and then all of which have been mitigated, and I will have you take it from here.
Awesome. Thank you, Ariel. I really appreciate it. And wow, there's like 700 people on the call right now. And so I just want to say thank you for taking time out of your schedule. I know everybody's kind of obviously back to work, end of summer mode. Fall is rapidly approaching. Trader Joe's pumpkin stuff has hit the shelves, which means there's a major change in seasons right now. So what I wanted to talk to you about tonight, I was invited to talk to you about some of the treatments, really the pharmacologic treatments of presbyopia. And, you know, this is obviously a hot topic. It's been around for quite some time. We've had some experience with 1 or 2 drugs on the market, but I think it's really important to kind of take a deep dive into the world of presbyopia, primarily because more stuff is coming. And that's really the reason why we're having this talk today. So my talk is, I named the call, the slide deck, Pupil Size Matters, the Pharmacologic Treatment of Presbyopia that actually works. And we're going to get into stuff that is actually working better than what was out there before. For those of you who are looking at this, you know, or too young to know who this is David Bowie. This is his Starman image, and pay particular attention to his pupils if you could. So I do have to go through this disclosure that all of this information in this presentation is my opinion only, based on peer-reviewed information that was gained through the public domain. I have no financial interest regarding anything discussed in this presentation, and all information, I do work at Walter Reed, which is a Department of Defense hospital, and I do want to say that all of this stuff that we're discussing today is my opinion only, and it is not the opinion of the United States government, Department of Defense, Department of Veterans Affairs, or any other governmental organization or contracting company. All right, so we are going to go to the chat right now, and I am going to ask the crowd, does anybody know why David Bowie had a blown pupil? And if you could put your answer in the chat box, that would be great. And be specific, because there's a funny story behind it. Was not drugs. Let's see if anybody can get it right. Bam. All right. Looks like Madison Ruel. He got in a fight with his best friend as a child over a girl in elementary school. That is 100% correct. And so if I do see you in the future, I owe you a drink somewhere at some conference. All right. So moving on over here. Let's see. I'm trying to get my slides to advance. There we go. So the objectives of today's talk, we're going to discuss the anatomy of the anterior segment and the physiology and mechanism of action of presbyopic near vision decline. We're going to discuss options of presbyopic correction and the optical properties of a presbyopic correction, and review the current and future pharmacologic options for the correction of presbyopia. All right, I'm just going to try to minimize my cameras over here. Can you guys see my slides okay? There we go. Perfect.
Yeah, you're good.
Okay, great. And I'm just having trouble advancing these slides. Let's see. Aha. All right, slide number 1. I hate presbyopia. So I am over 45. We'll just leave it at that. And, you know, for those of you who are younger than me or younger than presbyopic age, the worst day of an optometrist's career is the day that they wake up presbyopic. And I will tell you, when I was younger in my optometric career, and I used to get patients coming in with a chief complaint, no less than that, obviously, and you see it all day, all the time, of people complaining about the decline of their near vision and the fact that they can't see up close anymore, especially you know, low hyperopes that don't have the ability to take off their myopic prescription. It's life-changing. It is terrible. It's the worst. And so really, you know, the solution to presbyopia, in my opinion, is almost like the, you know, the holy grail of optometry. It's something that every single person, if you live long enough, as we all know, goes through. And the reality is that if we didn't have plus edition glasses at a minimum, we would be making people over 45 unfunctional. So look, I know everybody's an optometrist on the call or in the eye care industry, but let's take a look at the demographics of this problem. Just to remind ourselves, you know, I honestly think that we take for granted so many of these problems. They're just, there's so many presbyopes that we become numb to it at some point in time. I'll parallel it to diabetes even. I think as a profession, because we see diabetes so much in our population, approximately 11.7% of the US population, that's less than 1 in 10 Americans, are diabetic. I think that we've become numb to the fact that these patients are coming in with one of the leading causes of blindness and also one of the leading causes of death in the United States. And so we don't take, in my opinion, we think of diabetes as this manageable disease that that so many people have. It can't really be that bad, but it's terrible, obviously. And the same thing with presbyopia. If you think about it, before the advent of Luxottica, or whenever they started in Italy, centuries ago, we never had a solution to presbyopia. And just imagine how bad your life would be if that was the case. So right now in the United States, out of a population of 360, 370 million, approximately 40% of the United States is in the presbyopic age of their life. There's 4 million new presbyopes a year, and adults on average lose 1.5 lines of near vision per 6 years. Those are pretty dramatic numbers. If you put that in terms of a different condition of the eye or of the body, you would say, wow, this is pretty significant. This is something, if we can find a solution for this, that would really impact the population. Obviously, this is the joke slide, but I was going through and putting the slide deck together. There's been strong evidence of man trying to eliminate presbyopia dating back to cavemen. As I was going through this, it was funny because I do work on the AOA's evidence-based clinical practice guidelines. While I found this on the internet while doing a search for information, is not what I would consider strong evidence. However, there are groups out there that would. If you wanted to say, I did research and found that smoking extends people's life, I'm sure you could find it, but that's not really the information that we want to really produce to the public. And so you really have to be careful with what you're reading. So again, we've got 800 eye doctors, and we're going to talk about presbyopia, but let's take a really good look at it. The pathophysiology of presbyopia and the accommodative system. So 3 major components that are going on. And, why do we want to look at this? Well, I think if we look at these 3 components, if there's 3 problems that can occur, then there could be 3 solutions that we can possibly tap into. So there's obviously a gradual thickening of the natural lens. There's a loss of viscoelasticity of the natural lens. And this is actually how it works in the accommodative system. Then this happens within the lens fiber cells from protein cross-linking. We all see this all the time when we dilate our patients. Obviously, patients going on to having cataracts is obviously a problem, but the pre-cataractus presbyopia is pretty significant. And obviously, there's treatment options and challenges. And I'm sorry to be so basic about this, but I do want to look at how many, just to give you an idea, and I don't think we really think of how many presbyopic solutions, potential solutions there are out there. So in terms of glasses, obviously you can have single vision near glasses, bifocals, trifocals, progressives. Then we have the contact lens department where we have, single vision lenses, monovision lenses, modified monovision lenses, soft lenses, rigid gas permeable lenses, scleral lenses, also custom molded scleral lenses now, and they're alternating. There's multifocals, alternating, simultaneous, and these have been going on and on and on. I've been in optometry as an optometrist for 25 years. This hasn't stopped. I mean, and we all know this. The solutions. Every single year, something new comes out. If it's a contact lens manufacturer, continuous contact lenses come out that are better and better and better, or they said they're better and better and better for the solution of presbyopia. And then, of course, outside of our world, as optometrists, there's some solutions. Well, some optometrists can actually do PRK now, so that's not outside of our scope of practice in some states. But surgical options, you have LASIK, you have PRK, monovision, inlays, CKs, IOLs that are monofocal, monovision, extended depth of focus, accommodating lenses. And then there's even some more kind of non-mainstream surgical solutions, scleral expansion bands, CK, LTK, blended LASIK. If anybody's been around the LASIK block as long as I have, back in the early 2000s, Vizx actually came out with a software package for their laser. I think it was, if I'm not mistaken, it was the 3.67 software package that they were using the Vizx laser with a blended, bilateral blended treatment LASIK-wise. So it was almost like a progressive treatment for LASIK. And that since we're not seeing it today, that obviously failed. But there's so much stuff that's out there. For those of you who have never heard of conductive keratoplasty before, again, this early 2000s, early 2000s, this came out, where an ophthalmologist would take a probe and shove it into the cornea, probably about 60, 70, about 5 to 7 millimeters in diameter the way down, and then yes, it was about 70% of the way down, and they would step on a pedal, and there would be an electronic pulse, and that would actually shrink the cornea, and they would put this around the pupil, and you can see if you look in between those conductive keratoplasty spots, you can see where the cornea actually tightened up in the mid-periphery to give a more blended aspheric shape to the cornea. And some people thought that since you can actually move the cornea, and it's pretty interesting how some techniques emerge, that since you can actually move the tissue on the cornea and shrink the tissue, they thought about actually applying it. There are some doctors in the United States and outside the United States are still doing this today on keratoconic patients, where they're using a conductive keratoplasty device that was actually invented for the reduction in near vision problems and using it for keratoconus. And you can see what this surgeon did over here was, if you look at the topographical map, put all of these spots to kind of shrink the tissue where the cone is, to kind of try to regularize the cornea. And as you know, this there are a few surgeons that are still doing this in the United States. They're few and far between, because I think it's just not as reliable as we want it to be. And this one was what I think was probably one of the more violent ways to kind of get rid of presbyopia. These were called scleral expansion bands. There was a company called the Refocus Group that I don't believe they're doing them anymore, especially in the United States. But if you can see in the picture in the bottom right, it's more it's an older kind of illustration of a surgical procedure where they actually have to resect the conjunctiva, get down to the sclera, make tunnels in the scleral tissue, and put these scleral expansion bands in the sclera. And what that does, they put them in 4 quadrants at least, and then put the sclera back on top of it. What that would do is actually stretch the scleral tissue away from the center of the globe. So it would actually pull it away. If you think about it, essentially what they're doing is the opposite of what a scleral buckle does. So whereas scleral buckle is a belt, obviously, that goes around the eye that kind of brings the eye to the detachment, or the eye to the retina that's not attached. This one, it's the scleral expansion bands are trying to actually pull the eye away from the lens and create more space so the lens can actually start to accommodate more. And obviously it was pretty intense, and success rates weren't as great as obviously as we wanted them to. And so, when you think about presbyopia, presbyopia, again, as we all know, I can't believe I'm talking to 800 optometrists about presbyopia that are actually graduated already, but we'll get to the fun stuff in a little bit of this newer technology. But I think it's really important to go back and think about a non-presbyopic patient that has the ability to accommodate. And remember, when you're trying to come up with a solution to your problem, instead of looking at the problem, sometimes it's important to look at when the patient didn't have the problem and to see what was functioning well, and to see what you can do to mimic that kind of healthy, normal response. So when a person can accommodate and does have the ability to focus up close, that accommodation is obviously linked in our near triad. And I really think you have to think about this whenever you're thinking about presbyopia. And that's kind of a little bit out of the box for me. When I'm thinking about presbyopia and presbyopic correction, I'm just thinking add plus, add plus, add plus. But really, we know that we cannot unlink the near triad. So we also know that presbyopes don't go from, the ability to accommodate on a Monday, and then they wake up on Tuesday, and all of a sudden they have 0 level of accommodative ability left. They go. It's a gradual change, and I can obviously say that from personal experience. It stinks now, but it didn't stink as much when it started for me. However, I really knew what was going on and hated the idea. But so when you lose the ability to accommodate, you also have to realize that when the eye is still trying to accommodate, it's still trying to constrict the pupil, and it's still trying to converge at the same time. And we know that this near triad can't be unlinked. And so even though you're having a patient that is presbyopic, when the presbyopic patient is trying to focus, the pupil is also trying to constrict, and the eyes are still trying to converge. But if you break the triad or slow it down, obviously those functions go away. So, while the problem is really with the ability to accommodate, the meiosis and the pupil size still plays an incredible role, because the way that the eye was designed, it was designed to constrict when we looked up close. And so I think that's an excellent kind of transition. Since we're talking about pupils, I think that we have to start reminding ourselves about the light reflex pathway. And I would say that there are great neuro-optometrists that we have in our profession. To me, it's incredible. Some of our colleagues actually specialize in memorizing every single little bit of all of these highways and byways that go on the brain. But I think it's always really important to review these light reflex pathways, especially as it relates to presbyopic correction, because especially if we're going to, look at the pharmacological methods to regain some of that accommodative ability or ability to focus up close, it's working on these light reflex pathways. And so just to kind of take 2 seconds and review, obviously we have the efferent and afferent sensory motor pathways. But when we're having that kind of motor response, we always have to remember that there is a parasympathetic pathway, which is in charge of constriction, and there's a sympathetic pathway that is in charge of dilation. So again, just to review, the pupillary constriction takes place in the iris sphincter muscle. The response communication is between cranial nerve 2 and cranial nerve 3. One of the things that I try to discuss in all of my presentations, especially as it relates to pupils and cranial nerves, and what I try to, is whenever I get the opportunity to remind some students that, there are only 12 cranial nerves. And of the 12 cranial nerves, 6 of them either directly or indirectly affect the eye, which is to say that the visual pathway and the cranial nerves take up a heck of a lot of real estate in some very expensive neighborhoods inside of the skull. And that the eyes are obviously bound by all of these pathways, and it's really important to remind ourselves of these pathways. And quite frankly, today, this late in my career, not maybe that late in my career, I'm doing this for 25 years, I still am blown away by the fact that we can look right and left, and our eyes can land on the exact target, and at the same time that that's happening, a same target in space, and at the same time that's happening, both of our pupils are constricting or dilating to the exact same size, and they're talking together to land on a target so we can see perfectly. I still think that's amazing. And so, and I still can't explain it, but at least I can memorize the pathways. So these afferent pupillary fibers start at the retinal ganglion cell inside the eye, and you can see that in green on the eye that's actually on the upper eye over there. It says retinal ganglion cell. And then travels to the optic nerve, the optic chiasm, the optic tract, joins the brachium of the superior colliculus, travels to the pretectal area of the midbrain, which sends fibers bilaterally to the efferent Edinger-Westphal nucleus of the oculomotor complex. From that Edinger-Westphal nucleus, the efferent pupillary parasympathetic preganglionic fibers travel along the ocular motor nerve to synapse with the ciliary ganglion, which sends the parasympathetic postganglionic axons in the short ciliary nerve to innervate the iris sphincter, which is going to constrict our pupil down, the iris sphincter smooth muscle via the muscarinic receptors. And if we're going to look at the sympathetic pathway, right? So this is the opposite. This is not constricting. This is our dilation pathway. The pupillary dilation pathway is sympathetically driven, and that's important to understand because this is the way our pharmacological intervention is going to work through a three neuron pathway. The first order neuron begins in the hypothalamus, descends to the midbrain to synapse the spinal cord, ciliospinal center between C8 and T2. The second order preganglionic sympathetic neuron exits the spinal cord through the ventral roots, ascends through the thorax near the lung apex, and this is where we're looking for our lung tumors in patients with, Horner syndrome, all that kind of stuff. Subclavian vessels and superior cervical ganglion. The superior cervical ganglion appears opposite the second and third cervical vertebrae near the angle of the mandible, the bifurcation of the common carotid artery, and these postganglionic neurons travel along the periarterial carotid plexus through the cavernous sinus. Obviously ends up branches of V1, the ophthalmic division of cranial nerve 5, the trigeminal nerve, to synapse on the dilator muscle, causing pupillary dilation. And this is all happening all day long. And so it's really important to understand that even in your presbyopic patients, even though that triad is still there, and even though they can't focus up close because of the accommodation, there's still activity in the pupil. Like, we don't have patients that become presbyopic and then lose all their pupil function. And so really, one of the really important ways to look at presbyopic correction after looking at the way it normally functions is to look how we can alter the non-properly functioning pupil. And so small aperture optics, it's all about the pupil. And of course, we've been, given a ton of information by the Vuity, the pilocarpine solution over the past couple of years. That's obviously a very old drug. I remember talking to one of my colleagues not too long ago and saying to them, because myopia management obviously is an incredibly hot topic in optometry today. A couple of years ago, obviously everybody was talking about Vuity all the time, and I remember saying to them, I said, if you told me in 1999 when I graduated from optometry school that in 2024 the two most popular drugs that we would be talking about are atropine and pilocarpine, I'd probably smack you in the face and tell you were crazy, that we haven't made any progress whatsoever. But the reality is that two of the most common drugs that we're still talking about today, as of 2 or 3 years ago, were atropine and pilocarpine. So thinking about how important apertures are, and I do have 2 daughters. One's a senior in high school. One's a sophomore in college, and obviously, Instagram is the most important thing in the world to them, taking pictures. Obviously, the whole world has figured out, through all their great Instagram posts and everything else with selfies, on how aperture use and camera use and depth of focus is so important to taking pictures, especially if, you're taking pictures of your lasagna at your favorite Italian restaurant on Saturday night. You got to get the greatest picture in the world. Obviously, you got to find a way to use the focus on the best lens on your camera to the right aperture so you get the right depth of focus, so you get the good blur in the background to make the picture look fancy. And so if you take apart these cameras, because this is the most common use of depth of focus in the population right now, and small aperture optics, you can see inside of these iPhone or smartphone cameras how important that aperture is to taking pictures, and how variable it is and how much it can move. And so you can see that whole aperture component inside of the smartphone in front of you. And why do I bring this up and why is that important? Is because if it's good enough to take pictures for your Instagram page, it's probably good enough to make you see clearly with your eyes. And so if we apply these aperture optics that have been used, billions of times every single day on all of these smartphones, and apply it to our eyes, well, maybe we can get somewhere here. And so this slide I thought was very funny. I said, I call this one, what's the f-stop over here? You can see there's obviously on this iPhone Pro 13, over here, there's 3 different cameras, and you can see that there's an ultra wide camera, a back camera, and a telephoto camera. And looking at the properties of it, if you look down at the bottom of this table, you can see the aperture and how each individual camera has to use a different f-stop on the camera to get the wide field versus the telephoto versus that back camera into focus. Aperture size really is everything. The image size, the resolution is the same on all of these cameras. The ISO is, a little bit different. The minimum, maximum exposure is all the same. The autofocus systems are relatively the same. The flash is all the same, but the f-stops are going to be where you really get your difference in depth of focus over here. So if we start to talk about small aperture optics, why is it important to understand small aperture optics? Well, we really want to start talking about depth of field, and that the depth of field is going to be defined as the range of clarity in space, and the depth of focus is the corresponding range intraocularly. And so those are the two major terms that we're going to be using to describe this over here. So we all know what the pinhole effect is, especially with our disease patients, that if we make a pinhole small enough, we can make that light parallel as it comes into our eyes. Small aperture optics work by blocking unfocused peripheral light rays. They allow central light rays to focus on the retina and thus extending the depth of field. At the same time, they'll reduce higher order aberrations associated with more peripheral optics. So for me, and I didn't discuss this in my disclosure, but before I started working at Walter Reed, I worked at TLC Laser Eye Centers for many years. And during that time, we went from really what we would consider, non-custom LASIK. So it was everybody came in with a -4 prescription. They all got the same size treatment. They all got the same metal laser on their eye in the same location, and there was no tracking device. We just basically told the patient to hold still, hold on to the chair, and good luck. And so obviously that changed, and especially with the Vizx platform, where we were, all the software changed on it. We started doing customized treatments, but we had to start measuring the higher order aberrations prior to the LASIK procedure. And it was really interesting because one of the things that we started to do is we really, in a general optometric or general ophthalmologic environment, was really start looking at higher order aberrations and how they affected overall prescription. And what was really interesting to me was, number one is as pupil size changed within these aberrometers, as the pupil got bigger, the eye got more minus. Well, that makes sense. That's why, a lot of our patients have that night myopic shift. They get more minus and they start to have more light scatter inside of their eye. But as their higher order aberrations measured higher. And so one of the things that we found was as the pupils got smaller, the higher order aberrations lessened, and their prescriptions, overall prescriptions changed. So lower order refraction changed. And so higher order aberrations plays a tremendous role, obviously, in our refractive capability, and also the point spread function, as you can see on the bottom over here, how much light scatters. So when they started looking at depth of focus and pupil diameter, the magic number of below 2 millimeters dramatically increased the depth of focus and near vision. You can see the table on the left, which is comparing total depth of focus and pupil diameter, and you can see that it really optimizes right at that 2 millimeter mark is really where, if you can get below 2 millimeters, a little bit below 2 millimeters, you can really increase the depth of focus of an image in space. Also, if you compared the pupil diameter vision, near vision especially, and the depth of focus, and if you wanted to look out how many lines of improvement of vision you can get when you decreased your pupil diameter, once again, that 2 millimeter mark, if you can get below 2 millimeters, when comparing patients with different size pupils, you can actually get a large improvement in near vision if you can get that pupil below 2 millimeters. Okay, great. So there's lots of drugs and stuff out there that can actually do the trick. And so we're going to look at that for a second. The concept of small aperture optics was not limited to just the pupil or just our iPhones and smartphones. Obviously, this was implemented in surgical environments as well. And so for those of you who don't know what a corneal inlay is, this is a device, a surgical device that's made of polyvinylidene fluoride. And it's a little black disc. It's got thousands, it looks like 8,400 fenestrations within this optic with a 1.6 millimeter aperture. And so this was the cornea, like a little pocket was opened up, almost like a LASIK flap kind of. And this was put in the cornea, probably about 30 to 40% of the way down in the cornea. And it would sit in front of the pupil, and this would go into the non-dominant eye. Or there were some docs that were actually putting it in both eyes. But this would help increase the depth of focus of the patient. These were happening a lot, and then they started getting explanted a lot. A lot of patients wanted them out, and I don't know how many of these are regularly being done anymore, but during the heyday, they started getting really getting put in a lot. And even more than that, these small aperture optics are actually finding their way into intraocular lenses over here. This is the Apthera IOL, which is FDA approved in 2022. And you can see the aperture, and this is obviously at the lenticular plane. This is inside the eye, not where the iris sits in the bag. This is a one-piece foldable IOL with an aperture inside of it. Has a 1.3 millimeter aperture. So that magic number below 2 millimeters is really come true, not only for the pupil size, but also for these inlays and these IOLs as well. So when they were looking at the corneal inlay, they were doing all of these aperture range tests and looking at shallow depth of fields and the greatest depth of field, and comparing them with, using cameras. And just to give you an idea of what it is, with f-stops on a camera, for those of you who aren't, camera nerds, which I guess many optometrists are, the higher the number of the f-stop, the larger the aperture is. The higher the number, the smaller the aperture is. And you can see over here, they came up with, again, in different studies in different groups, 1.6 millimeters of diffraction and dimming and 1.6 millimeters loss of effect of the depth of focus being the magic number. I just love this picture on the right over here, where you can see these targets looking at an SLR camera with an f-stop of 5.6. Remember, we were looking at f-stops of like 22 over here for these really small aperture optics with the greatest depth of focus. This camera over here, and you can see in this example, was using an f-stop of 5.6 at 7.69 feet with a 4 millimeter pupil. Obviously, and you can see a lot of the cards that are laid out are blurry up close, blurry far away, and there's a very short zone of clarity over here because of the aperture size. But when you change that f-stop to an f-stop of 22 with a 1.6 millimeter pupil at the same distance, 7.69 feet, excuse me one second, you can see how much increased depth of focus you have. I'll go back to the slide before so you can take a look at these images. F-stop of 5.6, 4 millimeter pupil, f-stop of 22, 1.6 millimeter pupil. You can see how much increased depth of focus you have over here. So obviously, aperture size, pupil size is the trick to getting that increased depth of focus and increased quality of vision up here. And this was the final camera inlay design over here. Again, not the greatest thing in the world. So instead of going into mechanical strategies like the IOL and the inlay, let's talk about the pharmaceutical strategies to treat presbyopia. So if we were talking about a drug to treat the lens, that would aspire to work directly on the flexibility and the accommodative ability of the crystalline lens and restore its elasticity. That's pretty tough. We'll talk about that one in a second and what studies were going on. And then the other option is using a pharmaceutical strategy to treat presbyopia with a pinhole optic. This one aspired to reduce the pupil, to expand the depth of focus, to bring near vision into focus without impacting distance vision. That's really important, right? So, you can squeeze the eye, make the eye get contorted, use drugs to change the anatomy of the eye, but you also so you want to increase your near vision, but you definitely don't want to take away from your distance vision at the same time. And so, we've all had that patient that wants to have refractive surgery. That's a -2 sphere. That's 51 years old. That's coming in saying, "I want to have LASIK. I want to have LASIK. I want to have LASIK." And obviously, it would be a slam dunk at a -2, assuming everything else is normal. But by making that patient emmetropic at distance, you're gonna crush them up close. So we have to find a way to improve the near without sacrificing any distance at all. So the pharmacologic approaches to presbyopia, we have two different classes: lens softeners, which treats the underlying causes, and the miotics, which affect pseudoaccommodation, extend the depth of field of the smaller pupil. But this may lead to a decrease in retinal illuminance and diffractive anomalies if it's too small. So the question is, where's the sweet spot? Well, the sweet spot we've found to be somewhere between 1.5 to 2 millimeters in diameter. And I can see that there's folks putting questions into the chat. What I'm going to do, just to let you know, is I'm going to get through the slides, try to answer as many as we can at the end. And for those of you who I can't get to question-wise, they're going to give me a printout. The folks at Woo U are going to give me a printout so I can actually go through those questions and reply back to you, since you registered with your email. So if I don't get to you tonight, I appreciate it, and I promise I'll get back to you. So the lens softeners, two different types of drugs over here. You have topical lipoic acid, choline ester eye drops, and then also there was a drop, fructosyl amino acid oxidase, and both of them are trying to break down the crosslinks in the aging fibers. I just think it's really funny. On the one hand, we are trying, with cross-linking and everything, just because I have I really enjoy working with keratoconus. On the one hand, we're trying to create cross-links in the cornea to make keratoconus stop, and then you find another treatment to get rid of cross-links in the lens so you can actually get the lens to start moving again. And if you think about it just from a different perspective, we spent our entire career trying to get patients to put UV coatings on their lenses and in their contacts and on their everywhere you go, you want to protect them from ultraviolet light exposure. And then, we're like, oh, you have keratoconus, let's put some riboflavin in your eye and expose you to as much UV light as it takes to stop the cornea from moving. So obviously, one person's problem is another person's solution in this world, and you use what you can to get to where you want to get to. So let's talk about those miotics that are used for presbyopia treatment. And I think it's important to look at the details, because a lot of people think like, one drop is one drop. We tried Vuity, it worked okay, didn't work great, and there were some issues. And I'm done with using eye drops for presbyopia. I do want to tell you that in the beginning of this presentation, one of my disclosures was that I'm on an advisory board for a company that's named Lens, L-E-N-Z, and they are supporting this lecture tonight, and I am on their advisory board, and they are one of the miotics drops that we're going to be talking about tonight. I just want to make that completely clear, and that it's a different type of drop, and I'm going to go through it with you from here on out. And they're not FDA approved yet. Maybe they will be soon, but they do similar things to pilocarpine. My point being is that I don't want everybody to get down on small aperture optics so much just because you think one drop is all drops. That's not the case, and I hope I'll show you why over the next couple of slides. So, and admins, but something just happened to my computer. I just want to make sure you can see my slides okay right now.
Yes, we can see them.
Okay, great. And are you seeing this advance to carbachol?
Yes.
Okay, great. So first two drugs over here, pilocarpine and carbachol. Both of those are non-selective cholinergic muscarinic receptor miotics. The third one, and this is the Lens product, the generic name is aceclidine, and they're still cholinergic muscarinic receptor miotics. However, this is a selective cholinergic muscarinic receptor miotic, not a non-selective cholinergic muscarinic receptor miotic, and that's a big difference. Also, lots and lots of you know about brimonidine, which is a sympathomimetic and alpha-2 agonist, inhibits dilator muscle. It also increases bioavailability of cholinergic miotics when used in combination. We're going to get back to that in a second. And for those of you like me who have been around the refractive surgery world for quite a few years, you may remember when we had patients with lots of glare, we would actually prescribe them brimonidine to use once or twice a day, not to lower IOP, but to constrict their pupils a little bit to see if that would help with their glare. And that worked medium, I would say, at best for those patients. And last but not least is a drug called phentolamine. It's a non-selective alpha adrenergic agonist. It is FDA approved as the brand name Ryzumvi, or in combination with cholinergics for presbyopia. However, I do want to point out that the indication for Ryzumvi is not for near vision purposes. It's for the reversal of mydriasis, whereas other drugs that are on the market trying to get FDA approval are for the purposes of increased near vision and reduction of presbyopia. So remember, I wanted you to remember about this selective cholinergic muscarinic receptor versus the non-selective cholinergic muscarinic receptor. And the reason why that is that the non-selective muscarinic cholinergic muscarinic receptors can actually cause ciliary muscle stimulation. And we've all heard about this using pilocarpine before, where you can get a myopic shift, you can get pseudomyopia and that ciliary spasm headache. And with the ciliary, because it's nonspecific and it does affect the ciliary muscle stimulation, it actually can also, in rare cases, as we know, but it does happen, anterior lens displacement and thickening, which can cause an induced retinal traction and a potential for tractional retinal tear, and potential for posterior synechiae formation. And so really, the question is, if you're going to make a drop that's ideal for presbyopia, you would want it to make a pinhole pupil somewhere between the 1.5 and 2 millimeter zone, while avoiding a myopic shift that we talked about before. And we also don't want it to impact distance vision. And so that's complicated. And so when we're looking at this stuff, the FDA, when these drops are being submitted for this purpose, the FDA is requiring 3 lines of near vision improvement while not losing 1 or more lines of distance vision to get FDA approval for these drops. So as a result, this company, Lens, L-E-N-Z, they had their drop. Their drop is LNZ 100, which is 1.75% aceclidine. They had developed a study called the Clarity study. The Clarity study was a phase 3 multi-center double-masked randomized controlled efficacy and safety study. There were 3 phases of it: Clarity 1, Clarity 2, and Clarity 3. Clarity 1 and 2 looked at the 2 and 6 weeks efficacy trials. So how good was the drug? How well did it work on vision? The endpoint was looking at the percent of patients that achieved 3 lines or greater of improvement in best corrected distance visual acuity at near without losing 1 line of distance vision at 3 hours post-treatment. And also, the drug in the Clarity 1 or 2 study efficacy, 2 and 6 week efficacy trials, 71% of their patients achieved 3 lines or greater improvement of near vision at 30 minutes, while 40% achieved 3 lines or greater improvement at 10 hours. And think about that for a second. If this is a drop that you're putting in at 8 o'clock in the morning, and you've got to work an 8 to 10 hour workday, you're getting a significant amount of improvement in your near vision. Is it going to work for everybody? No. Is it going to give people 100% of improvement so they get their 25-year-old near vision back? No. But what are our presbyopes, looking for? It's improved quality of life and improved, near vision, so they can accomplish their tasks hopefully free of some sort of tool like a pair of glasses or contacts, obviously. And this is pretty impressive data. Clarity 3, where Clarity 1 and 2 were efficacy trials and how well the drug worked to improve vision. Clarity 3 was a 6-month safety trial. And what they found after 6 months of use with this 1.75 aceclidine eye drop is that it was well tolerated with no serious treatment-related adverse events across, and this was observed in all 3 Clarity trials. There were a total of 1,059 patients enrolled in the study between the ages of 45 to 75, and the refractive range was from -4 to +1 spherical equivalent. And I think it's in the slide coming up, but I believe these weren't just virgin eyes, there were actually post-refractive surgery patients included in the study as well. And so when they were looking at the efficacy trials, on day 220, they did something really interesting. On day 223 of the Clarity 1 and 2 trials, 223 recipients were surveyed who received LNZ100, which is the 1.75 aceclidine, and 90% of them stated that they noticed an improvement in their near vision, and that 75% said that they would want to continue to use LNZ100 after the study, of which 81% noted they expected to use them 4 to 7 days a week. Pretty impressive. Again, this is not FDA approved yet. This is phase 3 clinical trial data that came out of this Clarity 1, 2, and 3 study. And I just received a message not too long ago from some of the folks at the company that the company Lens Therapeutics that makes this drop officially submitted their FDA new drug application to get FDA approval exactly a month ago today, which is neat. And so let's look at some slides over here. So being that it's a selective miotic, it's not going to have, you can see here that it's not going to have that effect on the ciliary muscle, which really was part of the scary part of pilocarpine, all formulations of it. I'm not just saying Vuity, was that, the ciliary headaches and also the increased risks of retinal detachment. Looking at aceclidine, the selective drug versus the non-selectives, pilocarpine and carbachol, and slightly different concentrations, how many of them, of the 3, could they achieve a less than 2 millimeter pupil without myopic shift? And interestingly enough, as you compare an even stronger concentration of the aceclidine versus 2% pilocarpine, 3% carbachol, you can see that there was actually much less of a myopic shift in these patients because this drug is a selective version of it. Oops. Let's see here, next slide. And we're getting there, folks. Thank you for bearing with me for this information. This was the study design. Interestingly, there were actually 2 studies that they looked at in the Clarity trials. They actually looked at LNZ100 and also LNZ101, where they actually added, I think you may remember, we talked about brimonidine being a drug that you can actually use in combination with other drugs to help bring the pupil down. It just showed that the addition of brimonidine didn't actually increase the near vision. So using the drug in the vehicle, so the LNZ100, the aceclidine 1.75% plus the vehicle, ended up being the right combination drug. Here we are looking at the percent of participants achieving greater than 2 and greater than 3 lines of near vision improvement. over from a half an hour all the way up to 10 hours. One of the things that I notice here is that the improvement in near vision stays consistent over time throughout the day, which is great. You can see 2 lines. If you look at the half an hour and the 1 hour, greater than 2 lines of improved near vision, you're talking like 91, 95%, which is really incredible. 3 lines, which is the FDA endpoint, 3 lines or greater, that was achieved at 71%, was achieved at 3 hours, the primary endpoint. So it did hit its primary endpoints study, which is great. The percent of participants achieving, percent of participants achieving near vision improvement by line. So you can see the x-axis, 4 lines, 5 lines, 6 lines, 7 lines, and 8 lines. And we're looking at the drug versus the vehicle. And you can see, obviously, there's significant improvement of the drug, the vehicle, not really giving you that much improvement. Percent of participants achieving near vision improvement by line during the study. And so obviously you can see here between moderate presbyopia, 2050 to 2080, and advanced presbyopia, you can see what percentage of those patients increased vision and how many lines. Percent of participants achieving greater than 3 lines of near vision improvement over day 1 through day 28 over here at the 1 hour, at the half hour, 3 hour, and 10 hour intervals. The drug obviously increased near vision, had near vision improvement across all 3 segments. Obviously, the drug at any point, any drug is going to start to wear off at some point throughout the day. But to say that towards the end of the day that this still had some near improvement is really, really impressive at the 10-hour mark. The percent of participants achieving greater than 1 line of distance vision improvement. So one of the criteria was to not lose distance, but look how many patients actually improved their distance vision improvement. Obviously, some of that coming from the pinhole effect that they're looking through. And like we talked about before, adverse events. You can look at the LNZ100, which is the drug versus the vehicle. You can see that there was some site irritation installation upon putting the drop in, visual impairment, hyperemia, and the non-ocular adverse effects were the headache. And you can see that obviously the drug is obviously very well tolerated. 100% of all of the adverse events were mild of all things. There were no retinal detachments. There was no significant brow ache like you see in typical pilocarpine either. And over here, you can see the Clarity 1 and 2 and Clarity 3, that if you look at each patient that participated, these 378 participants, and if you look at them, each one of them every day for the duration of the 42 days and the 180 days that they looked at them, each day they're available for an adverse event. And you can see over here, the serious adverse events were just not there. There was some mild irritation. And that's all I got, folks. I think I took you right up to almost that 1 hour mark over here. My kind of final thoughts on this is that just like everything in healthcare, you may start out with a decent treatment, and as you learn what works and what doesn't work, and as you get better and improve your technology, these solutions will get better. So I personally think, and this is my opinion, this drug will likely become FDA approved. And I think that it's very much worth a shot because I think I think that generally speaking, we didn't have a great experience with pilocarpine the first time around as a presbyopic treatment. However, I don't think you should disparage all other pharmacological solutions to presbyopia just because you had a bad experience with one. And I think this I have not used it on my eye. I want to be clear about that. But based on, I get to look at clinical trials every day of my life. And based on the results from this, it was a clean study. And the results look very, very promising. And I hope this helps our patients in the future. And that's all I got. That's all, folks. Ariel, I'm going to turn it back to you. And I think we have some questions. Do I have time for questions right now?
We're at the end of our time. I'll just ask one resounding question, and then I know you said you were gonna get
Sure.
to some of the other questions that were in the chat box there. But if you had to look into your crystal ball on when this drug would be available pending FDA approval, do you have kind of like a rough timeline that it may become available?
So I'll tell you this, and I know this is a really crappy answer for 814 people that are on the call right now. If I bet money on what the FDA was going to do every time something came out, I would be broke. The answer, the answer is the FDA is going to do what the FDA is going to do. I would say, I would hope, and this is just my opinion, that, since we just started this school year for my kids, I hope by the end of this school year, we are going to see something FDA approved. Do not hold me to that. I don't work for Lens. I don't work for the FDA. I've seen things get fast tracked and I've seen things get slow tracked, but I would keep your eyes open. To the best of my knowledge, they're going to start showing up at our meetings, and I think that's probably a great way to engage the folks from this company. Go to their table, talk to them, ask them questions, and I think they'll be better to, better to provide that information to you. I would also visit their website, and I'm sure that they have their people on the website with contacts. I would reach out to them directly. I'm just not the right person for that. I'm sorry to say that.
Well, all 814 of us are going to hold you accountable for it.
Thank you very much. But I do owe somebody a drink, and so whoever that was, they have to hold me accountable. The only question right at the beginning. I just want to say, Ariel, thank you so much for hosting tonight, and thank you so much for Woo You. I know they do a great, Stephanie and her whole team does a great service for optometrists by getting them this free continuing education credit. And obviously the folks at Lens that are pushing hard to try to get something to help our patients. This is just a great platform, and I hope you guys will have me back in the future. And thanks for giving up an hour of your night with me tonight. I really appreciate it, and I take it very seriously that you gave up your time.
Awesome. Well, thank you so much for this super informative lecture. Everybody had really great comments in the Q&A and chat area, and we look forward to hearing from you next time.